we can go on to the next topic of the basics of reading fundus fluorescein angiography. I invite Dr. Ajay Aurora for his talk.
Good morning and thank you, chairpersons. Thank you, KSOS, for giving me this opportunity. So it's after a long time, many years, that I touch back upon basics of reading fluorescein angiography. I hope I'm able to do justice to it. We have looked at, I will not touch some of the basics of why fluorescence happens, but basically go on to how do we read an angiogram. And this is the fundus camera which we are using. We use many other wide angle systems, so things have changed a little bit. But essentially, we need to have a venous access, and we need to be prepared for any emergency situations. We need to know the time it takes for the fluorescein to reach the retina, that is the arm retina time. And hence, we should know about the phases of angiography, the arterial phase, the arterial venous phase, the early venous phase, and then the late venous phase and the recirculation phases. So we should know the time which it takes, which is about 12 to 16 seconds for the fluorescein to appear in the retina, and if it is delayed, then we know that the arm retina time is extended, and that becomes a basis for diagnosing maybe an ocular ischemic syndrome. So the definitions are, what is hyperfluorescence? Hyperfluorescence when there is more dye present or our ability to detect to a greater amount of the dye which is normally present there. That basically means that you have a leakage, which means there is an increasing fluorescence with the time, with blurring of the margins of the fluorescent. There is a pooling. So whenever we say pooling, it means that there is a collection of dye in a fixed space which gets once filled up. It may increase in intensity but not increase in size. Therefore, the margins will be discrete and not blurry. Window defect, you can imagine if you have an entire room and you have a small window and you look at the amount of light coming into the room from different parts of the day, the early part of the day when the sun directly shines in and when sun goes down, the amount of fluorescence which is coming from the choroid, as the choroidal fluorescence increasing, the window defect may change. And then we have staining, which could be because of the fibrovascular tissue which picks up the dye. So these are the principles of hyperfluorescence. Then you have hyperfluorescence when there is basically less dye present or our ability to detect the dye is lesser, which could be a reduced perfusion like a vascular occlusion, or there could be a blocked material like there may be blood present, melanin present, or excess lipofuscin, or there's a loss of vascular tissue like in a myopia. We will just rapidly go through it. So supposing we have a situation where there is leakage into the sensory retina, there's cystoid macular edema, there's again hyperfluorescence. Then you have neovascularization like in a choroidal neovascular membrane. And then you have associated with drusense, that is again hyperfluorescence. Then you can have a window defect where you have an RP atrophy. So whatever choroidal fluorescence is there, it is discrete, it is appearing as a window defect, and it is based upon the choroidal phases. Then you have a pooling of the dye which occurs under the retinal pigment epithelium, or like in the CSR, it may be a neurosensory retina. Now, this is a wide field view of a patient who had come to us with a C-fan neovascularization, and you can see the hyperfluorescence, which you can clearly make out the C-fan neovascularization. Please look at this wide angle view. This is again a patient of a proliferative diabetic retinopathy. You can see that there is a neovascularization of the disc, so you get hyperfluorescence on the angiogram. You have NVE, again you get a hyperfluorescence on the angiogram, but simultaneously you have other findings, like you have a reduced peripheral perfusion, which means there is a hypofluorescence. Then you have areas where you have hemorrhages, which caused blocked fluorescence. So all these findings you must, when you write down, must say which are the areas of hyperfluorescence, which are the areas of hypofluorescence, and what do you think could be the cause. This is again to show the same thing of hyperfluorescence from the disc. Now in a CSR, you can have an ink blot sign. So this is an extrafoveal leak, which in the earlier years we used to treat with a focal laser, like a photofomentation, which we now do with a micropulse laser. This is the lesion, or you can have a smokestack appearance. That means because of the osmotic gradient, you can have a movement of the fluorescein within the neurosensory detachment, but it is in a restricted space. Now here is a patient which is a wide field view where you can show the lasered area. So when you have a lasered area, the central area is hypo in nature because there is an RPE proliferation, while at the margin of it there is a hyper, which is basically because of a window depth. So you must understand the pathomechanism between what is happening at the level of the fluorescein angiography. Now, wide field angiography actually helps us to pick up areas of non-perfusion in the periphery which were missing out earlier, and these are the cases which we are able to laser in cases of a recurrent vitreous hemorrhage. Now here we have a patient who has got, this is an autofluorescence, but you can match the colored picture with a blue autofluorescence, with a fluorescein angiography, which you can see there's a diffuse retinal pigment epitheliopathy with a teardrop sign like on an angiogram, so you know that it is a old CSR, chronic CSR, which has affected the retinal pigment epithelium. Then you can have a blood blocking the front, which could block either above the retina, a pre-retinal hemorrhage, which means it will block the retinal fluorescence as well as the choroidal fluorescence. But if you have a sub-RP blood or a sub-retinal blood, then you will have the retinal pigment, the retinal circulation will be preserved while the choroidal fluorescence is blocked. Like in this case, there is a vascular occlusion, so there is an area of non-perfusion. And here you have a myopic patient where as such there is a loss of vascular tissue. Now this is a patient who is a post-COVID BRVO. You can see here there is a vascular occlusion and a non-perfusion. So this is hypo in this area. This is the case of a peripheral exudative hemorrhagic chorioretinopathy. So you can see here on a colored picture we make out that there is a large area of a hemorrhage. And if you look at the angiogram, you see this hemorrhage is blocking not only the choroidal fluorescence, but to some extent the retinal circulation. You can still see the retinal circulation here because the blood is thinner, but if you have a blood present over the retinal surface, then both the things get blocked. This is again an example of a sub-RP blood. There's a large area of blood which is a corresponding FAF, and you can see that the angiogram, the retinal circulation is seen, the choroidal hyperfluorescence is not seen. Similarly, simultaneous FA-ICG, then here you have a pre-retinal hemorrhage, you find a neovascularization, so you have a hyper, then you have a hypo because of presence of a pre-retinal blood. Now, you may ask, why should a fovea appear dark? The fovea is darker because it is avascular, because it has got tall RP cells which have melanin, which blocks the fluorescence, and you have a presence of xanthophyll. I'll just take 2 minutes. No issue. Okay. So similarly, now coming to reading the angiogram. So this is a patient who had a proliferative diabetic retinopathy, and if you see carefully, this is the choroidal fluorescence which is at 17 seconds. Even in at as late as about 53 seconds, the fluorescence has just appeared. What does it mean? It means that there is a delay in the arm retina time. That means it is a case of a proliferative diabetic retinopathy with an addition of a possible ocular ischemic syndrome. Other features you have to, phase by phase you look at. We will not go through them. And this is just to show you the colored picture. So the prolonged arm retina time, then you have to investigate for the ocular ischemic syndrome. This is another patient who came to us with a severe NPDR in both the eyes. This is an angiogram. So basically in different phases of the angiogram, we can make out that there are multiple microaneurysms that are leaking. There are areas of hemorrhages. You have to go to each smaller area and see where there's a blocked fluorescence. But we were able to make out that there is a possibility of a small NV in this area. And when we look at the color picture, we may not make out the NV. So there lies the importance of doing an angiogram. In these cases, sometimes you pick up an NV which you had not detected carefully in a busy practice. Okay, so this is similarly the same patient in the right eye where we are able to see, and then when we do that, this is a patient who was massively lasered, and she came to us with a vitreous hemorrhage in the right eye. She had cataracts, so we thought maybe it's PVD induced, but when we looked at her angiogram, we saw that she had this NVE present elsewhere, so we went ahead, gave her an intravitreal injection, subsequently did a cataract surgery, and then went ahead and lasered her. She had been extensively lasered all over the place. Now, another thing which I wish to introduce is a non-invasive way of doing a fluorescein angiography. So this is a documented way of doing an oral fluorescein angiography, especially if you have a SLO-based image. So we had done a study many, many years back where this is an oral FFA, and the same patient we pictured on an oral FFA, and the same picture we patient on an IV FFA. So at about 12 minutes, we could see the fluorescence. At 18 minutes, again, we could make out the membrane. At 22 minutes on an SLO-based Heidelberg system, you can actually make out. So if you have a patient who is allergic to fluorescein, you can actually go ahead and do an oral fluorescein angiography. Please look at this IV angiography. It does not give us an extra information from this one, which is an oral angiogram, and this one, which is an IV angiogram. Therefore, in certain situations, with an SLO-based image, it may not work very well with a normal fundus camera, but in an SLO-based system, you may be able to get a better angiogram. So the take-home message is, whenever you have to do an angiography, have a plan for each angiogram. Always have a clinical photo and a red-free, which basically means with a green filter on, before you interpret an angiogram. Follow a sequence of taking pictures. If you have a normal angiography, you have the 7 fields which you take. If you have a white field, then it becomes very easy. Do not interpret the angiogram while you are recording it. You know, I've seen this, I know this is it. Don't do that. Complete the angiogram and then look at the series. Do not talk about the diagnosis. First talk about all the observations you make. You should look at the arm retina time. You look at all the areas of hyperfluorescence. While describing an angiogram, describe the choroid, describe the disc, describe the vessels, and while doing an angiogram, always be ready for an emergency. For a patient with a renal involvement, take clearance from a nephrologist. But what I have seen recently is that most nephrologists are happy to give you permission. What we do is when we have a creatinine which is above 2, we may give a lesser dose. We have an SLO-based system, so we can give a lesser dye and yet come up with a good angiogram. Thank you for your...
Thank you, sir, for the excellent presentation with the beautiful photographs and everything.
Yeah, before I conclude, I have to share a non-academic slide, which is this, which is me and Dr. Ajay are standing for elections next year. So this is non-academic, so I am going to remove it very rapidly, and we will look forward to your support.
Okay, sir, all the best, sir. So one question,
Yes,
1 or 2 minutes. So you said something is CSR, focal laser. So usually CSR beginning, we have a conservative treatment. So how long you will wait with the conservative treatment when you go for focal laser?
So I do not treat a CSR patient at least for 6 weeks. It's a masterly inactivity, 6 to 8 weeks. In case the patient is, we do an OCT, we see that the patient is overall improving, metamorphopsia is improved, patient is clinically improved on the OCT, then we wait. I do not do a thermal laser now because I have a micropulse. We have a large series on micropulse on CSR cases. We normally don't treat an acute CSR. Acute CSR also we have treated with micropulse, but we normally do not wish to treat. After 6 to 8 weeks and even longer than that, then only we treat it with a micropulse laser, not with a normal thermal laser.
Micropulse laser means Nd:YAG or something else?
No, so micropulse laser we have 577 nanometers. It is a laser which delivers, it is an on time and an off time. Supposing you are giving a pulse of 200 milliseconds, then the pulse, and it is a 5% duty cycle, then the pulse is on for 10 milliseconds and it is off for 190 milliseconds. The concept is with that area, there is a recovery phase for the RPE so that it actually is a non-damaging laser and it can be done transfoveally. So you can go right through the fovea without damaging the fovea and it works fairly well.
One more question, sir. You said something oral fluorescein angiography.
Yes, yes.
So what's the what is the percentage? How many ml you will give?
So what we used to do, we used to take 2 vials of 20% fluorescein mixed in orange juice, about half a glass, and ask the patient to take it, record a basic SLO angiogram, and then we used to, that time, record it almost every 4 to 5 minutes. After 10th minute, we almost record it every minute because it's a very slow process. And we generally get a reasonably good angiogram for basic interpretation.
How the patient last up any nausea, vomiting, anything?
No, sir. The patients are very happy with it.
So only thing urine discoloration, anything?
That is all same because the excretion remains same. So you definitely have to take a. It's only the allergy, the intravenous allergy, the anaphylaxis, which is taken care of.
Any conjunctival discoloration? Nothing.
Sorry?
Conjunctival discoloration, anything?
No, it doesn't.
Okay.
Thank you.
So, thank you, Dr. Aurora, for that wonderful talk. Just one or two parting tips on FFA. One is always have a crash cart ready. Those who are doing FFA, please have a crash cart ready. Second, don't leave the patient without a 1 hour observation, at least following the procedure and documenting the vitals after your FFA. Third is always, if you feel that there is, even if the patient has no comorbidities, there is no harm in checking creatinine. Check creatinine on your own, and if it is high, please have a renal clearance from the nephrologist and not from the physician, from the nephrologist itself, and document it. And lastly, if you really feel that a patient is at risk because of the angiography, nowadays we always have the option of an octa. So try to get an octa if you feel your clinical situation an octa can cater to your clinical situation. So that's also an option these days. Thank you.
So thank you.